Well, I'm Dennis Thompson. I am affiliated with Lakeland Hospital. I'm one of their physicians, and I am here to talk tonight about sleep apnea. What do I know about sleep apnea? I am a board-certified physician in the specialty of sleep medicine, as well as being board-certified in ear, nose, and throat surgery, head and neck surgery. So I have those two backgrounds in training, and puts me in a good spot to talk about surgery, especially for treating sleep apnea, although most of my patients get treated with CPAP machines. So I forgot my wife's advice about always starting with a joke, so I don't have a joke. So if I see some faces, you look like you're waiting for a joke. It's going to be a long wait. I don't have one. But I would like to know who I'm talking to just a little bit. So if you don't mind raising your hand if either you have CPAP or you live in a household where somebody's got CPAP, can you raise your hand? Okay. All right. So we got the majority of people in here are probably pretty familiar with sleep apnea and CPAP. So I can move maybe a little bit faster and get to the more interesting stuff that comes later. But we will do a little background. We'll save quite a bit of time for questions, because at these forums, when I've done them in the past, people always have their own questions, and I don't always hit everything people wish I had said. So this is our team of sleep medicine specialists at Lakeland. Once again, we are fortunate to have basically all the specialties that are involved in taking care of patients with sleep apnea represented at Lakeland. Dr. Sarubian is an internal medicine physician who is board certified in sleep medicine as well, which is probably the most common way that people get into sleep medicine. Dr. Ward is a neurologist, and sleep has a lot to do with neurology, and there are a lot of neurological conditions like Parkinson's and multiple sclerosis and other things that affect sleep. And so a lot of neurologists get into the sleep medicine thing. So he's also double board certified, but it's neurology and sleep medicine as well. So we're in a pretty good position at Lakeland to take care of sleep issues no matter what angle they're coming from. So here's our topic for tonight. What if you can't wear CPAP? Then what do you do? And we'll talk a little bit about why the subject would come up. If you know anything about CPAP, it's a fairly straightforward thing, so why wouldn't that work? These are our objectives. Try to understand what the problem is with people having trouble using CPAP. Understand what surgery, since I'm a head and neck surgeon, what that can have to do with treating people with sleep apnea, and then the newest technology, hypoglossal nerve stimulation, and we'll explain that in a minute. I don't have any conflicts of interest to disclose. Nobody pays me anything unless I take care of patients. So there are no companies that pay me anything. So CPAP Compliance. This is a CPAP machine. If you've never seen one, the machine's over here. It's a box about the size of 2 tissue paper boxes, one on top of the other. And that tubing is plugging into that. And there are lots of different kinds of, this is called headgear. There are lots of different kinds of headgear. This thing here is called a mask. And actually, that particular one is also known as nasal pillows because it seals kind of into the nostrils. But there are masks that cover the nose like that. There are masks that cover the whole face almost. And there's different headgears. But that's the basic idea is let's get some air into your throat, not to help you breathe, but just to keep your throat open. It's what you would call a pneumatic splint. It's a splint to keep the throat from collapsing, using air pressure to do it, but you're still breathing for yourself. And there's no extra oxygen. These people are just getting 21%, just like the rest of us, just room air. You can put extra oxygen in if the patient needs it. If they have emphysema or some other health lung problem, you can put extra oxygen in there. Well, our compliance problem is not unique to sleep apnea. Anything you have to do every day for a chronic problem, how many people have ever forgotten to take the pill they're supposed to take? Yeah, me too, you know, and they're in my pocket. I'm supposed to take it at 5 o'clock. I'm already late. So, you know, it's hard to remember. And so we find that with lots of important problems, asthma, 30 to 70% of the patients don't take their asthma medicines like they're supposed to. Patients with severe heart problems, 30% of them 3 months after their heart attack, they already forgot about the heart attack. 30% of them are already not doing what they're supposed to do, taking the pills they're supposed to do, going to rehab, whatever. High blood pressure, one of the most common, 51% of Americans, so it's 50-50. Half the people with high blood pressure take their pills the way they're supposed to. And this isn't even talking about the diet. I know nobody follows the diet, but this is just take your pill, you know. And cholesterol medicine, 25 to 50% of patients quit taking that cholesterol medicine within a year of somebody prescribing it to them to help you avoid some trivial little thing like a bad stroke or a terrible heart attack. You know, say, I don't want to take that medicine. So we have a problem with compliance, you know, with on any sort of long-term chronic problem. So it's not surprising we have trouble with compliance with somebody strapping some big old thing on their face, right? PAP adherence is important, though. The results of treating obstructive sleep apnea does depend on how well is it controlled. And if the way you're controlling it is with a CPAP device that blows air into your airway and you don't use it, then you don't get very good results. That kind of makes sense, right? The payers, the people who are paying for the machine, do require adherence, and the machines spy on you if you're using one of those machines. They communicate now. They used to have a memory card. Now they just communicate directly to the cloud, whatever that is, right? But anyway, the cloud is watching you, and it communicates using these Wi-Fi towers for your cell phone towers. And so they're all over the place, and there's very little place where these machines can't communicate. And in the small print, when you rented the machine or your insurance company got you the machine, it says you give them permission to send this information. So they're watching to see if you're really using it or not. And guess what they do if you're not using it? Take the machine back. Yeah, right. They take the machine back. If the machine's already paid for, they don't take the machine back, but they quit paying for your supplies and equipment. It doesn't get supported by your insurance company anymore, which makes sense if you're not using it. So you could caption this one yourself. We could have a contest to see who can make up the funniest caption for this picture. But when we treat CPAP patients, we frequently say, we're solving two people's problems because it also treats the snoring. You don't snore when you've got a nice wide open air passage. So the bed partner sleeps better too. All right, so alternatives to CPAP. What else is done? In children, the treatment is tonsillectomy with adenoidectomy. Because in children, that's usually the only thing that's obstructing their airway, is their tonsils and adenoids. So everybody who takes care of children, not just throat surgeons, the pediatricians, the pediatric sleep medicine specialists, everybody agrees children who snore every night should be evaluated to see if they have sleep apnea, and if they do, they should have a tonsillectomy and an adenoidectomy. So that's pretty straightforward. This is just a graph showing how bad their problem was before surgery and what it was after surgery. So it doesn't work every time. You have to reevaluate the kids. And that's the problem. In case you're not sure what you're looking at, these are teeth, open mouth, tonsils. This is all supposed to be black here. That should all be air passage. And this poor little kid has no place to breathe. And I operate on these kids every week. I'll do some tonsillectomies for throats like that. Now for adults, you got a lot of options. Not a lot for serious sleep apnea. So we do classify sleep apnea into mild, moderate, and severe categories. You have to have 5 events per hour that are significant, that last at least 10 seconds, where you're having trouble breathing, to get the diagnosis. Less than 5 is just considered plain old snoring. If you're in the 5 events to 15, we call it mild, because the research has not really shown a significant effect on bad health problems like high blood pressure, high blood sugar, strokes, heart attacks. Those things don't seem to be more common in people with just a little bit of sleep apnea. It can, even the mild category though, it can make you pretty miserable. It can still make you very tired during the daytime, no energy, a lot of fatigue. So even mild sleep apnea can be important to the patient, but it's not as dangerous. And it's easier to take care of. There are some treatments that we have that will work for mild cases because they're not as hard to handle, but they won't work for more severe cases of sleep apnea. So mandibular advancement devices fall into that category. These are usually made by dentists. We have a real simple one that we can make in our office. I'm not a dentist, so I can't make a real complicated one. It's less expensive, so it's probably a good starter anyway. You don't invest thousands of dollars in a device that you're not sure you're going to be able to use or tolerate or like. And they work by, again, everything with sleep apnea, it's all about airway collapse. The airway collapses, and all the treatments are to keep the airway open. And the way, how would something that you stick in your mouth keep your airway open? Well, it moves your jaw forward. Your tongue is attached to the front of your jaw. So if the front of the jaw moves forward, the back of the tongue moves forward too. So it opens up that space between the tongue and the back of your throat. Okay, so instead of the tongue being back here, it's up here. So that's how they work, and they work very well for plain old snoring. If that's all you want, is to not bother your bed partner, they work great for that. And they work pretty good for mild sleep apnea, but they're not very good for severe sleep apnea. Just don't do enough. And they can have some problems, as you can imagine. If you move your jaw way out like that, you know, your jaw joints might start complaining about it. You might wake up with headaches. Most of the time, those things will go away, though. With time, people get used to them. Can also throw your bite off, where after a year or two of using it faithfully every single night for 8 hours a night, now you can't chew lettuce on your back teeth, right? Yeah, your bite changed the way your teeth fit together. So some people really don't care for that too much. If you go into it with your eyes open, if your dentist tells you that your bite's going to change and you want to use it, I think it's fine. Elevation sometimes works. That's real simple. Some people, you've seen that ad, Sleep Number beds, right? They have a cute ad on TV where the guy's snoring and she raises the bed and he stops snoring, and then she starts snoring and he raises the bed and she stops snoring. Sometimes that's true, sometimes not. So elevation does sometimes help. Positional therapy helps quite a few people. When we do sleep studies, we record how you're breathing during your sleep, and it also records what position you're in. And it's not unusual to have patients who have a lot more breathing problems if they're flat on their back than if they're on their side. And sometimes they have nothing when they're on their side. They just absolutely do not have sleep apnea if they're laying on their side. But if they're on their back, they have bad sleep apnea. Well, instead of giving them a gadget to stick in their mouth or a mask on their face, we give them one of these, which is just a Velcro belt with a big bolster like you'd have on the back of your couch, you know, that's in the middle in the back. And during the night, if you roll over onto your back, you won't stay there because it's uncomfortable. And it just makes you roll on over to your other side. And those work pretty good. Sleep doctors maybe aren't super enthusiastic about them because we have to trust the patients. We have no recordings. We don't get any records. You know, we don't really know whether you're using it or not. Maybe I could make some money if I invent one that'll report to the cloud, right? I need one of those. But it's a nice low-tech, you know, it's not electronic. It doesn't cost $1 zillion to buy it. You don't have to keep it up. It's nice and simple when you have a patient who this will work for. Radiofrequency ablation is an old technology really that's just it can be applied to any tissue that you want to shrink down. It's radiofrequency, also called microwaves. You know what microwaves do. Most of you have a microwave oven at home. It heats stuff up, and you can ablate anything. I mean, the liver doctors will stick it in your liver to ablate a little benign tumor. You can ablate anything. So we use it to open up noses that are all stuffy because of soft parts that are too big. And we can use it in the back of the tongue. I said that other device moves the tongue forward. Well, instead of moving the tongue forward, why don't you just make the back of the tongue smaller? You can, okay? You can use this device for that. And you can use it in the roof of the mouth. If the uvula, the little hangy down thing in the roof of the mouth is too big, the roof of the mouth, the soft palate needs to be tightened up. We can numb it up and stick this needle in there and zap it a few times and tighten it up. So that helps, again, usually fairly mild cases, so doesn't really do much for really severe sleep apnea. Improving the nasal airway is a real common thing we do if you have very mild sleep apnea or just snoring and you have a really bad nose, can't breathe through your nose, and we get you breathing good through your nose, you'll be better. And sometimes we hit a home run and you're not snoring at all and you don't have sleep apnea. But it's not real reliable. About 25% of people who have a bad nose and sleep apnea, and you get them a good nose, you fix their nose somehow, their sleep apnea goes away. 75% of the patients, yeah, they say, thanks for the good nose, but I'm still snoring, I'm still not sleeping good. You know, it does not get rid of their sleep apnea. So the other place we use this sort of treatment, a lot of those patients, half the patients that get CPAP machines don't use them very well. Well, some of those patients, it's because they're very uncomfortable, they're having a great deal of difficulty getting it to work right, it just doesn't feel good. A lot of those patients, the reason is they have a bad nose. You're trying to blow air through their nose and it's mostly blocked up, right? So it's very difficult and uncomfortable, and the things leak, the air leaks around. And so fixing their nose frequently will move those patients from the can't use CPAP to the, oh, CPAP's no problem group. And we shift them over to where they can use CPAP by improving their nose. So this is a normal, I keep saying the throat closes up. What's the throat look like if we put a scope in the nose and hang it over the back and look straight down the throat? This would be a good throat. I don't see very many of these in my business, but this is the voice box. These are the vocal cords here. This is all the air that you breathe that keeps you alive, goes through a little space about like that, about the size of a quarter. Imagine that. And this is the rest of the throat. The epiglottis is part of the voice box. It kind of flaps down over that when you swallow, so you don't get your milkshake, you know, down in your lungs. And the rest of the throat with the base of the tongue up here. And that's a nice wide open throat. And here's some different throats that are not so good. This is more typical of what I see with my sleep apnea patients. Here's all this tongue, and it's pushing the epiglottis back, and you've got this small space, and you can't see the vocal cords. You know, where are they? You know, they're kind of around the corner, sort of halfway covered up. And this is with the patient's awake in this picture. When they fall asleep, it gets worse. This is another kind of sort of circumferentially small airway. That's the epiglottis, real small airway. Here's one you can't see any airway. This is tongue. That's the epiglottis. That's the back of the throat. You know, how does any air get down this throat? I don't know. That's why the patients wake up so much, because every time they fall asleep, their brain says, oh my gosh, I can't breathe, and wakes them back up, because your brain knows that you breathe okay when you're awake. All right, so that's just a cartoon sort of picture showing the same thing, laying on your back. Tongues in these patients, the tongue tends to fall back and block the airway. You're trying to get air here, you can't get it there. There's that radiofrequency ablation we talked about. This is a newer technique where it's kind of a modification of something we were doing in the 80s and 90s. We were basically taking out tonsils and sort of trimming the uvula. It was called a UPPP. Anybody here had one of those UPPPs? Yeah. Dr. Fujita in Japan invented that operation and popularized it. And his initial results were very, very good. And it got very popular real fast. But the late results, the longer you kept track of the patients and kept touching base and evaluating them, the less wonderful the results were. So it turned out that it wasn't really a cure-all for sleep apnea after all. But this is kind of a modification. We really don't do anything to the uvula. We take the tonsils out if they're there, take this muscle and bring it up here and kind of pull it forward this way. Remember that jaw thing that moved your jaw forward? Well, this is kind of moving the soft palate forward permanently by rearranging the muscles. And that does get much better results than that old operation. It's kind of an improvement on it. So we do those occasionally. Gyneglass Advancement, instead of putting a plastic device in your mouth to move your whole jaw forward, which might bother your jaw joint, you can do this operation where you cut the jaw right where the tongue muscle attaches to it, cut a little window out, slide that forward, and then screw it back, but on the surface, on the face, So you moved it out and screwed it back to the face, so you moved it out permanently some distance. I've never done that operation, and it's not a real popular option, but it's possible. This one has a high success rate. This is an interesting operation that was invented in the late 1980s and 90s out at Stanford University. And based on the same idea, if we could make more room in the back of the patient's throat by keeping the stuff that's in the front of the throat, which would be the soft palate and the back of the tongue, and get those things to be further forward. And they got the idea by studying normals, right? And they say, let's look at the people who don't have sleep apnea. And they found out with a lot of very clever research that, common sense, right? The people who don't snore and have sleep have more room in their throat. And the reason they got more room is that the upper jaw and the lower jaw are a little further forward. So there's a bigger space between the tongue and the palate and the back of the throat, which is kind of the front of your spine, right? So they talked to the oral surgeons who were doing this operation anyway for people who were born with sort of facial deformities, no cheekbones and their jaws way back here, and they just don't look right, and their teeth don't fit right, and so forth. So these guys were doing this great operation for these poor folks where they would split the jaws with a saw. If this is too much for dinner time, let me know. So they split the jaw with a saw, the upper jaw and the lower jaw, slide them forward, and then put plates and screws back in them to fix them back that way. So you can see that's going to open up a lot of room back here. The air passage is very small. Now the air passage is real big. And that works. Okay, that has a very high success rate. 85 to 90% of even severe sleep apnea patients are cured by this operation. How many patients have I had in 30 years of doing this that wanted to go have that operation done? 2. Yeah, it's a hard sell, and it might be easier if I was in a city where we had the surgeons who do it. My patients have to, get on a plane and go someplace. It's not a real widely available operation. I think both of my patients had it done in Milwaukee because there's a team there that does a lot of these. So that's an option, okay? But again, it's a big project to have your jaw split, your teeth get moved, you gotta get your teeth lined up right again, and so forth. It's not a real simple procedure to go through. So let's talk about, and we can talk about CPAP if you want to. CPAP does just use pressure, and in my practice, everybody starts with CPAP, just about, except for those kids that get their tonsils out. And you sort of never have anybody that's sort of in the middle that sort of likes it. They either love it or hate it, you know. And the people who love it really love it. They won't take a nap without it. They won't go, you know, they buy batteries to take it camping. And the reason they love it so much is that they feel so much better during the daytime. It's not that they love putting it on at bedtime. They love waking up feeling refreshed and energetic and ready to go. And they hate being sleepy all the time, you know, and tired. The curse of sleep apnea is that every time you fall asleep, you have trouble breathing, so you never sleep good, and sleeping more doesn't help anything because when you fall asleep, you don't sleep good. You know, you cannot sleep good when you've got sleep apnea. So you can't, there's no way to catch up. Naps don't help. Sleeping 14 hours a day doesn't help. I've had patients who were sleeping 14 hours a day, and they still can't stay awake in my office, you know. So that's why they love it. Any questions on any of that before we move on? Okay. So here's what we are here really to talk about, the latest thing, right? And this is an option for people who can't use their CPAP. These are the criteria. You have to try CPAP and prove that you can't use a $500 machine. You need a $50,000 gadget. Okay?
How do you prove that?
By trying it. By getting your doctor to prescribe it, and then you remember I said it spies on you, and the recording shows that you struggle to use it. You don't use it very much, you don't use it very many hours, you're having trouble, and plus you tell your doctor and we type it into your chart for your insurance company, okay? And I have had patients who got approved who they were using CPAP. They were just struggling with it. You know, it was better than nothing, you know, was kind of where they were, but they were very dissatisfied for it. And we were able to cajole them through the insurance company. So it wasn't like all or nothing. But most of the patients are absolutely come in, they gave their CPAP machine back. You know, I mean, they absolutely could not use it. You have to have moderate to severe sleep apnea, so it's not recommended for patients with very mild sleep apnea. We've got other things that work that are a lot simpler for those folks. Not significantly overweight means a BMI of 32 or less. And BMI is an index between your height and your weight that you can calculate. And 32 means you're kind of chunky, but you're not, you don't need a van. You know, you can get in a car, okay? So, and the right airway anatomy profile, and that is something that's determined by a required procedure where we put you to sleep and put the scope in your nose like we do in the office, except an anesthesiologist puts you to sleep so I can watch how your throat collapses during your sleep. And so I can see exactly. And if it collapses like a sphincter, like a camera lens, you know, around in a circle coming in, that's not very good because it just moves things forward. It doesn't keep that back, you know, stable. And that's only about 10% of the patients, though. So most of the patients really are candidates. So this is how it works. You're stimulating a muscle in your tongue called the genioglossus muscle. That muscle moves the tongue forward. So when you stick out your tongue, should we have everybody stick their tongues out? Nah, that's too cheesy. But when you stick out your tongue, the muscle that's doing it is called your genioglossus muscle. So most of us probably think of the tongue as being one big muscle. It's a whole bunch of muscles, really. And they've all got their own little nerve that tells them what to do. You can make your tongue fat in your mouth. You can spread it out over your teeth. You can move it back into your throat. You can practice all that while you're sitting here. You can stick it in this cheek or that cheek. All different muscles, you know, required to make the tongue do all that stuff. So the genioglossus is the one we want to stimulate, though, because that's the muscle that makes your tongue move forward towards your teeth or out from between your teeth. And this is basically how it works. You have a generator here, which has a battery and a little computer chip in it, like a little computer. And you have a pressure transducer, an electrode, a sensor It goes down to the muscle between your ribs so that the computer knows when you're having trouble breathing because the pressure in your chest goes up. And you have a wire going under the skin up here to that nerve that controls that muscle. And when the computer knows you're having trouble breathing, it sends a message to the nerve to your tongue to say, do that. Okay? That's how it works. Does it work? Yeah, it does work. So before they got their device implanted, this is how many episodes per hour the patients were having. This patient was having 140 episodes an hour. That's pretty bad. That's like the minute they fall, they basically can never breathe right. They're struggling to breathe the whole time they're asleep. These patients were having around 80, still very severe. These patients were having around 40. So they're all very severe sleep apnea patients, which are very difficult to get good results with the other treatments. And they all got better. Some of them you hit home runs and they got nothing. They just don't even have sleep apnea with the machine, with the device. Other patients got a lot better, not perfect, okay? As far as the patients themselves are concerned, though, not just their numbers, the results are better than this. About 90%, 90 to 95% of the patients think it's great. Even the sleep doctors look at their numbers and say, it's not perfect, but the patients say, this is great. It does decrease. It is important if you control your sleep apnea. If you don't do anything, this is how many patients are still alive at this many months after without a heart attack or a stroke. And you can see this is patients who don't get treated. A lot of them are not with us anymore. They're not being studied anymore because they've been planted. These guys, this is with treatment, right? Oh, sorry. So that top line is if you get treatment that works, okay? You get your CPAP machine, surgery. This isn't about what kind of treatment, but you get some sort of treatment that works, you have a lot better chance of being alive 10 years later. All right. So the answer to what can you do if you can't use CPAP is come and see me. We have a lot of options for what we can do. You have to individualize it very much. A lot of the patients who, since this hypoglossal nerve stimulation device is becoming more known, I'm getting a lot more people, coming in wanting to talk about it. A lot of them turns out, have a lot simpler solutions to their problem than that device, which is sort of a complicated, very expensive device. And we can still solve their problem, but with something a lot simpler and less expensive.
What's the long-term results of the stimulator?
Long-term results, well, the longest term we've got right now is probably about 8 years. I don't know if that's your definition of long-term. They're doing fine. That's still within the life of the battery, so those patients haven't even had a battery changed yet.
Is there any disintegration of the signal due to fatigue?
No.
Okay.
No, there's not. It depends on and how often it has to fire. Like that patient is having 140 episodes an hour. I would think they would use up their battery, because the machine must be having to fire a lot, to keep their tongue out of their way. And so there is a variation based on that. How often do you obstruct? And if you obstruct mostly in one position and for some reason your shoulder's hurting and you lay mostly on your left side that night for some reason and you don't really obstruct much on your side, you're going to save battery life, right? But they've had very little. The problems you can have, this technology is not real new. So the idea of a generator with some sort of computer program in it that knows when to do its thing, and then a wire that goes to some sort of nerve to tell it to do something, that's a lot older than this, okay? So some of you may be aware of nerve stimulation for chronic pain. You got some horrible pain problem, nobody can get it to stop. they put this thing, implant this thing in you, and you turn on the button, and it stimulates nerves that interfere with the pain message to your brain, and you don't have as much pain. Heart pacemakers, most people have heard of those. Same thing. It detects when your heart's not beating correctly, fast enough usually is what it detects. And a wire goes from the pacemaker into the heart. It's attached to the heart muscle and tells the heart when to beat. Okay, so that basic idea was sort of adopted, by the sleep doctors to say, hey, why couldn't we do the same thing for sleep apnea patients? Mm-hmm.
Is this information followed by the cloud? Any way, shape, or form, or do you have to come back?
I don't think it's followed by the cloud yet. In fact, I know it's not followed by the cloud yet, but they're working on that because we would prefer that, because then we would be able to check on how things are working, like whenever we want to. A patient calls up.
You have to
right.
do another sleep study on
Well, you have to come in the office. We have to do what's called interrogate the device.
Oh, okay, so that's
Just like
also
cardiac
anytime
pacemakers.
it's fine.
Yeah, right. Except the heart pacemakers, they've gotten pretty clever with those. They may be going to the cloud now, but the last time I got around heart pacemakers, they were able to hook them up to the phone
Okay.
and phone in the information from the heart pacemaker to the cardiologist's office, so you didn't have to drive in there yourself just to let them get data out of your heart pacemaker. And that's what we have to do with this thing. I mean, we actually have to have you come in the office to get the information out, but it's recording all the time so that you can tell if the patient says, gee, it was working great, but now I'm feeling so sleepy, it's like, and my wife says I'm starting to snore. We say, hey, what's going on with the device? Is there something wrong? And you have to come in the office. Mm-hmm.
When you get stimulated, does it wake you up? Does it...
No. So it's stimulating, well, I shouldn't say it that fast. It's stimulating a muscle-controlled nerve, not a sensation nerve. So you got two different sets of nerves in your body. One so you can feel stuff, including stuff that's painful, where you'd say, ouch. And then you got a whole other set of nerves that make muscles work, right? And the ones that make muscles work, you can zap them all day long. The patient's never going to say, ouch. That's not what they do. But whenever you zap it, some muscle's going to twitch, right? Whatever it's connected to. On the other hand, I shouldn't have said it quite that fast. If you make these muscles work real strong, it's like having a Charlie horse in your in your tongue, or these muscles under here, right? So if you overstimulate them, the patient feels like, ugh, I got a bunch of sore muscles, right?
So you adjust it?
Yeah.
Okay.
Yeah, it's all adjustable. You sort of sneak up on the power when you first turn the patient on to the machine, and so that you don't just sort of knock them out of bed, right? And but it's we haven't had, we've done 3 patients at Lakeland. They've done about 5,000 nationwide, because you had the first group that were research, where you had to get special permission from the government to do it, and the patients had to sign special papers and all that. So you had centers across the nation that did for 5 years, put them in patients on a research protocol. People in the community like me weren't allowed to put them in. And then when they proved to the FDA that the device works and is safe, then the FDA said, okay, anybody who's properly trained could do it. And they defined properly trained. I had to go over to Detroit and get trained one day. And even though the surgery is, I do this kind of surgery for a lot of other reasons, tumors and whatever in the neck. And technically the surgery is not much of a stretch for a neck surgeon. But still good to know what you're doing. So cost is, it's very expensive. So similar in price range to those other neuromodulators, they call them, those other implanted things, cardiac pacemakers, pain pacemakers. The total cost is probably, by the time the hospital buys the hardware, then the hospital marks up the hardware, right? Which is usually a pretty big markup, okay? And then you have to have an operation. So there's an anesthesiologist charge. There's the hospital's charge for using their operating room for 3 or 4 hours. There's the surgeon's charge, which is the least of your problems, believe me. So you're probably in the $50,000 to $75,000 range by the time you pay everything. Somebody's paying that. Somebody's paying that. which is why our biggest, out of all the steps you have to go through to get this thing, you have to come to my office. We have to have a sleep study that's fairly recent. You have to try a CPAP machine and not be successful with it, okay? You have to go to the operating room to get put to sleep so that I can take pictures of you, having trouble breathing, right? So all these steps. The biggest, hardest, most difficult step is getting the insurance company to say, yes, we'll pay for it. That's usually a 2 to 3 month process, depending on the insurance company. Medicare is one of the easiest ones, actually. Your tax dollars at work. Yeah, the government's not watching as close as Aetna, Blue Cross, United Healthcare. They're kind of Hawkeye and more than the Medicare. Yeah, Medicare is actually one of the easier ones to get approved. And of course, what it costs you, it just depends on your insurance policy. Co-pays, deductibles, high deductibles, low. That's your insurance company. Yes, sir.
Is it DC or AC current that's stimulating the nerve?
It's DC, direct current.
Is it very much or?
Okay, I'm not an engineer. I get this problem living in Southwest Michigan between the nuclear power plants and Whirlpool Corporation. Yeah, people come in and ask me questions I can't answer.
Is it hard to get used to when you first turn it on? Like, does it stimulate enough that it's hard to go to sleep? Or?
I haven't heard that, but we do go slow. So we bring the patient in the office about a month after the operation, let everything heal in, and we turn the thing on, with them awake. We had it on in the operating room so we could test it and make sure it worked. So if the patient's sound asleep under anesthesia, you can still make their tongue stick out of their mouth. When you get it all hooked, yeah, you get it all hooked up and you turn it on, and yeah. So if you're wondering what we're talking about, it's not subtle. You don't have to look real close to say, oh, is the tongue moving? No, the tongue goes like that. Yeah, the tongue moves. And it depends on how much current you give it. If you give it a strong current, it moves more. If you give it a weaker current, it moves less. But anyway, the first time it's turned on when the patient's awake is in my office about a month after, and a technical rep from the company comes and shows up to help us out, and they do a bunch of interrogating the device, make sure everything's working right, and then they do a process of just sort of easing up the power with the patient awake to say, well, what's comfortable, And most patients, you get to some level, you can't go from 0 to the strongest power and have them say, oh, it's fine. Most patients say, oh, that's enough, Feels like, just like a calf cramp, feels like they're getting a Charlie horse in these muscles under here. So you kind of ease up on it. But as far as how many milliamps it is, I don't remember. I didn't bring that with me. The company's great, though, I must say. We do have a lot of engineers in this area, and if they're into that, the company will hook them up with their technical, even the sales rep doesn't know all the questions that these engineers are asking us, and the sales rep's pretty knowledgeable about all this.
What company?
Inspire is the name of the company.
Are they the only ones making them?
They are, yeah, so they got a corner on the market right now. Going to meetings, I hear rumors or whatever that, they're going to get competition because this is going to be a pretty popular option.
It could be a huge market.
Yeah. And so there are people that are working on trying to come up with a competitive product. And obviously to break in, you got to try to figure out some way to make it better, have a little wrinkle, For instance, if it was easier to put in for the surgeon, if you had, instead of 3 incisions, you only had 2, that'd make it easier, quicker, less time in the operating room. They're working. There's other.
Put them in yourself.
Exactly. That'd be ideal.
What's the downtime? I mean, after you have this done, how long in the hospital and how long
Yeah.
do you work?
That's one of the other cool things about it, is that compared to the other surgeries I do, so surgeries that rearrange your anatomy are painful, okay? And those patients have kind of a miserable recovery, like a super big tonsillectomy, This surgery, working just under the skin in 3 spots, even though you got 3 sore spots if you hit them, but they don't hurt that much if you just don't touch them, So the patients take Tylenol or Motrin for pain, and they go back to pretty normal activities the day after. Well, that's not what I recommend, but it's hard to keep people from going back to normal activities because they really don't feel that bad. We restrict the motion of their right arm. We put these things on the right side and let the cardiologist have the left side for, that way if the EMTs pick you up off the side of the road, they don't think you have a heart pacemaker, So we put them over here, and you wake up with your arm in a sling. We don't want you moving your arm around with these wires, and pulling something loose or disturbing something.
Is it outpatient?
Yeah, it's outpatient. So that
You don't spend a night in the hospital or anything?
Now you sleep quite a while, but a lot of the time, my hands-on time actually working with my hands doing the operation itself is probably an hour and a half to 2 hours. The rest of the 3.5 to 4 hours is fiddling with equipment and technicians and waveforms of the electrical signal and stuff like that, making sure it's all working right. And a lot of precautions against infection. It's an implanted device, just like a knee implant or a hip. They're real hyper about infections because it's bad. And so we are too. We spend a lot of time making sure it's absolutely sterile. Yes, sir.
What's the physical size of this unit? I have a pacemaker.
Yeah.
On my left side.
Yeah, let's see. Yeah. A little smaller than that.
A little smaller?
Yeah, a little smaller than that. So about the size of a small pocket watch. I know pocket watches come in all sizes, but this will be a small pocket watch.
We can all feel his chest.
Yeah, everybody go over and feel feel his chest. Don't hit his chest, though. That might cause something to... Yes, ma'am.
The risk.
The risk, possible complications, like any surgery, you could have some unusual bleeding, you could have infection. Both of those would be much less than a 1% risk. I mean, very rare, which makes sense having done the surgery. There aren't really a bunch of great big old blood vessels that would be serious bleeding problems in the vicinity of where I'm working, so an injury to the nerve itself would be a problem because it does control your tongue motion. If somehow the nerve was damaged in the process of getting the electrode around it, that'd be a bad complication. But they really have had very little. People talk about long-term risk with the nerve getting scarring around it and then not working right. But so far, 8 years down the road, they haven't seen that with this device. And they did learn a few things from nerve stimulators that were being put in the 80s and 90s and trying to take that into account. I don't know.
So every time you walk
It's not
by
good
the
for
microwave, you go,
it's not good for a cardiac pacemaker. What do they tell you about microwaves?
I
Yeah.
haven't really discussed it.
It used to be a big deal. They were real sensitive. And I don't know whether the microwave ovens got better, more shielded, or whether the pacemakers got less sensitive to them. But they don't say much to cardiac pacemaker patients about it anymore.
I think it's more of the advancement of the pacemaker.
Yeah,
myself.
right. Yeah, several things that have happened with them. They used to also say absolutely no MRIs. Now it's not so absolute. It's no MRIs right here, But you can get an MRI of your head if they think you might have a brain tumor or something. You can MRI of your knee, So it's the area that you have to be careful with MRIs is shrunk for both of these products. Yes, ma'am.
My husband he'll sometimes get 11 hours sleep,
Mhm.
9 at night,
Right.
and then fall asleep on a sofa for
Mhm.
4 more hours. Does that mean he's not getting enough sleep, proper sleep at night?
Probably. That's the most common reason for people to sleep excessively during the night. There's a big long, I'm board certified in sleep medicine. It's an all-day long test. It's a 12-hour test. So there's lots of things that can screw up people's sleep or cause excessive daytime sleeping. So there's a big list, okay? But the most common one is poor sleep at night. Now, that's not necessarily breathing problems, right? Those of us who are, not teenagers anymore, It's like pretty much everybody in the room. We've collected our share of aches and pains, and I have some mornings where I don't really want to get up, but it's not from breathing trouble, it's from shoulders, hips, pain. So pain will wake you up, similar to the way breathing trouble wakes people up over and over again. Pain will wake you up over and over again, and you underestimate how often it happens. So it's sometimes a mystery to the patient. Say, why am I so sleepy? Yeah, my back was bothering me a little bit, once or twice during the night. Well, if you study them, put the brainwave wires on them and watch them in a sleep center, you can see that their sleep is disturbed every other minute all night long, not just once or twice, So, so you have to figure it out. But the bottom line is, the most common reason for somebody to sleep a lot of hours during the daytime is that they're not sleeping well at night. Mm-hmm.
So then he makes an appointment, goes to clinic, and then you have an all-night sleep study.
Correct.
Right?
Correct.
Is that in St. Joe?
Mm-hmm. Correct.
At Lakeland, okay.
Mm-hmm.
What is the waiting time for an appointment?
It's pretty long right now. We've been recruiting. Lakeland's been recruiting for another. They've been recruiting for everything. Actually, we have a shortage of everything, and so particularly in my specialty, ear, nose, and throat, head and neck surgery, we've been recruiting 6 years. And during the 6 years, this summer we're going to have 2 doctors leave and 1 come. So that's how good we've done in 6 years. So it's just getting harder. I don't think it's that much better in surrounding communities, South Bend or Kalamazoo. But so I can't answer your question right away. I can tell you our phone number, and I think they've got it in the back, don't you? And you can call and talk to the receptionist and see what the wait time is.
So one night, then you're able to diagnose the problem?
Well, you come in the office, and we take a look and see if I can figure out what the problem is without an expensive sleep test, right? That'd be nice. And make sure we order the right test. Don't want to order the wrong test and have to order the right test, and get 2 tests. So you come in the office for a consultation, and if we think a sleep study would help us, then we order it. There's also a wait for that, unfortunately. Things kind of drag because of our shortages of physicians and facilities in some cases.
And then you wait for approval of the insurance.
Well, for the device, but that's down the road. We got to get you diagnosed first. And insurance approval for diagnostic tests is really not a big deal. It's no deal at all with Medicare. Some of the private insurance companies do require us to get their approval for diagnostic tests that are expensive, like an MRI might be $5,000, and they don't want us getting them on just anybody, so they don't trust us, so they want us to tell them why we think the patient needs an MRI. So sometimes you do have to get, but not for sleep. I haven't run into that with sleep medicine, except that we have 2 sleep tests. We have one, a cheap one and an expensive one. Guess which one the insurance companies like better. So the cheap one's kind of like a mini sleep test, is do it yourself. And that's why it's cheaper, because you do it yourself at home. You take a kit home, you got a couple little bands and stick them in the recording device and go to sleep. And it's okay if you only want to know how the patient's breathing during their sleep. So you're suspecting sleep apnea, this breathing problem. And all you want to know is, do they have it or not, and how bad is it? And it's a really good test for that. And it's much less expensive than put them in a sleep center with 2 or 3 technicians there all night long, and an expensive facility. But in the sleep center, we find out how you're sleeping. Like, to answer this question, really, why is he sleeping 11 hours during the daytime? Why is he taking naps? What's wrong with his sleep? Well, you need brainwave wires and EEG to tell that, and you get that in the sleep center. You don't get it at home. At home, we just sort of assume that since you're still alive, even though you stop breathing every 3 minutes while you're asleep, you must be waking up every 3 minutes. So we just sort of infer that. Mm-hmm.
My wife is she's the one that's supposed to be here.
You're taking notes. Good job.
She's in Florida, so she said, you gotta go. She already has an appointment with you.
Okay, great.
And they give her, I think, 3 options. One was CPAP,
right?
and one was you, and I don't remember what the third one was. But anyhow,
Well, she made the right choice.
she needs to go to you
Correct.
regardless.
Correct.
I mean, Airway wants to set her up with a CPAP machine.
Well, if Airway set her up, she must have had a sleep test somewhere.
She did.
Right.
She had a sleep test
Right.
at Lakeland.
Correct. And
Yeah.
so she could go ahead and get set
They
up,
told
and
her
then
she
she,
never got a REM, never
Right.
got to REM sleep.
right. Yeah, you
Which
can't
is
get to
sleep.
REM sleep when you're waking up every 2 or 3 minutes.
Yeah.
You have to start in awake, and stage 1, very light. Stage 1 is that sleep that you do in front of football games. When the announcer says, "Oh my gosh, look at that," you open your eyes, you say, "Look at what? Look at what?" You know, you're just sort of barely asleep. Stage 2 is reasonable sleep, still not super restful. Stage 3 is very restful, deep sleep, where your memories get consolidated and your brain actually works better the next day. And REM sleep is where you do all your dreaming, which does something good for you, because if people don't get it, they don't function that well the next day. Yes, sir.
Does having sleep apnea, does it cause short-term memory loss sometimes?
It does. Yeah, so sleep apnea consequences, we mentioned the big ones, you know, like death. One of the big ones. High blood pressure is guaranteed. Sleep apnea always pushes the blood pressure up. Now, if you have low blood pressure to start with, maybe it only pushes it up to normal, but it always pushes it up. If you have high blood pressure to start with, it pushes it higher. It makes it harder to control. In the sleep business, we think that anybody who's on 3 blood pressure pills needs to have a sleep test. Whether anybody thought they had sleep apnea or not, something's wrong, that they're so hard to get under control. And one of the most common thing is that at night for 8 hours, there's something shoving their blood pressure the wrong direction, and then you're trying to shove it back down in the morning by taking all these pills, right? So high blood pressure for sure. High blood sugar, especially people that have a tendency to have elevated blood sugar, it'll shove it up, as will any stress. Struggling to breathe at night is very stressful. Stress increases your blood sugar levels. So again, makes it harder to control, right? You're going to your doctor, they're saying, "Oh, your hemoglobin A1C, it's too high. You know, what are you doing? What are you eating? What's wrong with you? Come on, get with the program. We're going to give you another pill." You know, if they're snoring, for sure, if they have any sleep problem, they ought to have an investigation there, because there may be a reason why their blood sugar is so hard to get under control. Daytime sleepiness. You know, what I tell patients is, is sleep apnea serious? Well, you know, people die from it. They either die slow from high blood pressure, high blood sugar, heart trouble, strokes, or they die real fast at 60 miles an hour when they fall asleep and run into a tree, right? And that does happen. Sleep apnea, untreated severe sleep apnea has the same effect on your driving risk, actually a much higher effect than driving drunk, than driving over the legal limit. Much worse, much more likely to have a serious car accident than somebody who's very drunk. At least the drunk guy's awake. He's probably gonna, you know, jerk the wheel or do something. The sleepy guy just goes, you know, right into that bridge, right? Yeah.
Dr. Thompson,
Yes,
I
ma'am.
thought we could take one more question.
Okay.
I want to be conscious of everybody's time because we're
Yep.
coming up on the hour. I want to thank you very much. And there is an evaluation in your bag, so you get to grade the doctor on his talk. And we'd also like to hear what other topics you might be interested in. So if we could take one more.
Okay. One more question. You've had your hand up.
If you know that your husband is not very good at following through with prescribed treatments.
Right.
Is it just husband?
Yes. And if you have said that they would need to use a CPAP before they're even looked at for
Right.
the latest surgery.
Right.
Have you noticed any improvement in the actual CPAP apparatus over the last few years? Because that is a horrible thing to have on your face.
I know, it's amazing some people love them, isn't it? There have been improvements in everything. In just the last they're constantly improving everything about it, okay? So the reporting, the electronics, the pumps, all that stuff, the stuff that you put on your head, the headgear, the mask, the way they get the air in you is much more comfortable than it was. I've been doing this 30 years. I mean, it's like night and day compared to what we had 30 years ago. So it all keeps getting better. Now, the closer you get to today, you know, when you say, has it improved a lot in the last 3 years? I don't know that there's been that much difference in just 2 or 3 years. 5 or 6 years, probably quite a bit.
So if we wait a little bit longer, then it'll be just a little bitty thing.
If you survive. Well, thank you for coming. I appreciate it. And we do have contact information at the back.